An obese and hypertensive 63-year-old Caucasian woman presented with persistent and progressively worsening exertional dyspnea, occasionally accompanied by angina chest pain, as well as dysphonia, hoarseness, dysphagia, complaints of lower extremity weakness, and documented mild chronic L5 to S1 denervation. Workup revealed moderate obstructive ventilatory defect, borderline restrictive defect, and variable extrathoracic obstruction. Weakness and progressively poor quality of sleep characterized by sleep-disordered breathing, increased daytime somnolence, fatigue upon waking, and increased snoring were added to her initial complaints. A sleep study established the diagnosis of severe obstructive sleep apnea. Treatment with continuous positive airway pressure produced significant improvement in her energy levels, more restful sleep, and less fatigue, but her dyspnea worsened. A new cycle of cardiac and respiratory evaluation was positive for mild pulmonary hypertension and negative for myocardial ischemia and pulmonary fibrosis. Shortly after these last assessments, and 2 to 3 years after onset of symptoms, the patient died suddenly in her sleep. The general autopsy revealed emphysema and cardiomegaly with no coronary atherosclerosis and no acute pulmonary or cardiac disease to explain sudden death. Gross examination of the brain showed only a slightly flattened left inferior olive. The spinal cord appeared normal. Microscopic examination confirmed mild, patchy neuronal loss in the left olive. Neuronal loss was prominent in the anterior horns of the spinal cord, with relatively few remaining neurons. There was no neuronal loss in the substantia nigra, striatum, cerebellum, or basis points, with only modest reactive astrocytosis and rare neuronal ballooning in the pons, medulla, and spinal cord. The cortical spinal tracts were unremarkable. Immunohistochemical staining for alpha-synuclein highlighted intracytoplasmic inclusions in the midbrain pons, medulla, cerebellum, and spinal cord. The inclusions were most numerous in the medulla and the gray matter of the spinal cord. The inclusions also stained for ubiquitin, but not tau. There were no ubiquitin positive inclusions in the motor neurons to suggest amyotropic lateral sclerosis. The diaphragm showed scattered groups of atrophic skeletal muscle fibers. The diagnosis was ultimately determined to be multiple system atrophy. So basically, a woman comes in, she's having difficulty breathing that gets worse when she exerts herself. She's having chest pain, difficulty speaking and swallowing, as well as lower extremity muscle weakness. Testing done showed that she had severe obstructive sleep apnea that they treated with CPAP. The CPAP helped improve several of her symptoms, but her dyspnea continued to worsen. Later testing showed that she had pulmonary hypertension, and she eventually died in her sleep. An autopsy done revealed that she had emphysema and cardiomegaly, but there were no heart problems that caused her death. And further testing of her brain and other body systems showed that she had multiple system atrophy. Words that I found in this were hypertensive, meaning having increased blood pressure, dyspnea, which is difficulty breathing, dysphonia, difficulty speaking, dysphagia, difficulty swallowing, extrathoracic, meaning outside the chest, myocardial is pertaining to the muscles of the heart, cardiomegaly is an enlarged heart, atherosclerosis is a buildup of plaque in the arteries, astrocytosis is abnormal star-shaped cells, and amyotrophic is lack of muscle nourishment.